Okay, so good afternoon, everybody. Thanks for tuning in. I just introduce myself to you guys. I'm Dr. Kaushik Naik, one of the co-founders of Dental Roots Education Pathway and Business Solutions. Uh, Today, we are launching our Dental Roots webinar series. And then the whole intention of doing that is a bit of a thought process within ourselves to see how are we going to be able to look at going back to work. Because over the last few weeks, we have been going through a few questions in our mind. And if I can sort of summarize them for all of us, we are thinking what's going to happen when we suddenly got this news on the 23rd of March that it's all going to come to a grinding halt. Following that, we also started to think how to get over this COVID-19 problem because it was quite a massive one in the UK. Yesterday, after the Prime Minister's speech, I think we are more or less assured that we are asked to go back, but in phases, even though we are not very clear about it, which is why everyone's asking this question of when are we going back to work, which we still are not sure about. We are going back to that's more or less like it, but we are not sure when. So we got to wait a bit for that. During that wait, what we are mainly looking at, what will be working in the new normal be like? That's the main thing that we'll be more or less focusing on. And all of us are, because the new normal itself is not something that any one of us are very clear about. How can I plan for this phase? Very clear from us today that it will be a very slow phase written for all of us. And what does that mean to we dentists? With all of that, one thing doesn't change, and that is to deal with our customers and what is the mindset of our customers. As we all know, all our customers or patients who come to our dental practices would like us to do good treatment. And that's the basic norm. That's what we need to do on every patient. But that is not all. In today's day and time, they also expect a wonderful patient journey whilst they are in the practice. But on top of it, purely after this COVID-19 situation, I think they'll be more critical about the safety experience that they will feel within the practice. And this is another big thing that we all need to start concentrate upon when we are talking about real value against perceived value. And just to give you a gist of what this real value and perceived value is all about, the real value is what we basically are going to provide to our patients throughout their journey in the dental practice. However, we need to keep an eye on what the perceived value is, which is what the patient thinks is value for their investment in money and in time. And as long as we are able to match their perceived value with the real value we give them, I think we are doing a great job in terms of satisfying them, and helps, in a way, helps our business to grow and also come back to a good stage where we want it to be. So I was looking at the factors that influences these things. I'd say one is the competition. The competition we always perceive in our field is the dental practice next door or the local population of dentists and so on and so forth. But if you actually look at it, I think that's not the biggest concern. For me, when I look at it, the most biggest concern is patient priorities itself. Where do we belong in their priority list? They want to buy a house, they want to buy a car, they haven't gone for a holiday for long, they want to go on a holiday. Now, where are you on that list? Because the higher you are on that list, the better the chance that they are going to accept your plan, whatever you're telling them. But to be on that list, there is one problem, which is what I call our weakness. And that is, not most of the people would not want to spend their time or their precious time in a dental practice. And that's not the best place for them to spend that precious time. However, I think the strength, on the other hand, is a beautiful, healthy smile we can create can enhance the happiness of the rest of the priorities for a patient. So that beautiful smile with a wonderful car makes a lot of difference. So this is the statement we are able to sell to our patients. But for us to do that, I think we should be able to have the skill sets to treat and give them what we say is a beautiful, healthy smile, but also to show the patient how much we care for their overall well-being. As a whole, if we are able to achieve that process, then they will be able to believe in our thought process, they'll be able to trust in our skill sets and then agree to what we tell them. Yeah. So what I was thinking was what was locked down to us. So lockdown has actually given us a lot of time to reflect upon all that I have sort of emphasized in my previous few points. This is, I think, probably the most amount of time I have got in my life to reflect upon how I have been working over the past whatever years that I've been working as a dentist. And that has probably made me rethink our strategies for the future on about it. So by doing those two, we can plan changes we need to make to accustom ourselves to the new norm. And so if we can do these three properly during this time, we can come out as a winner. And one of my friends always quotes that every crisis will bring to a set of new winners. And this is what we need to possibly aim at. So with all these things in mind, we have sort of discussed with a lot of different dentists from different fields to see how we can help our community over this period of time to get back into business using this forum as a sort of a refreshing platform. So with this basic view in mind, Dental Roots has organized a series of webinars free of charge, verifiable CPDs to cover the relevant aspects of dentistry that matters the most in COVID-19 dental workspace. Okay, so to do this, we have a wonderful set of speakers lined up and some amazing topics over the next few weeks this month. I will give a list of all the topics that are gonna have the webinars on what date and what time at the end of this session. But today, going forward, this is a very exciting moment. The topic for today is the route to remove roots, beneficial oral surgery skills for post-COVID-19 dentistry. And the speaker is my very close friend and a wonderful dentist, Dr. Darshan Boindala. Darshan, he's done his BDS and then he's done his medicine from Bath, Royal London. He's also done his MFDS RCS from England, following which he's done his master's in oral surgery and implantology. Darshan is also awarded Faculty of Dental Surgery Honorary Lecturer Award by FDS RCS. He's also a member of SAD, a member of ADI and the RCS, to name a few. Darshan is also working as an examiner for all the overseas registration examination. He is working in London and he mentors a lot of upcoming dentists for oral surgery and dental implantology. So he's accepted our invitation today to give us a very good guidelines about the basic oral surgery techniques, because this is one of the aspects we all feel is going to become very, very important as we get back to work. So without taking much time, now I'm going to be sort of passing on the screen to Darshan. Darshan, thank you very much for coming, sir. So I'm going to pass on the screen. I'll stop sharing. So if you can take over the screen from me, please.
Great, thank you. Hi, Kaushik. Sorry, I'm just trying to get the screen share to happen. Sorry, 1 second. Great, okay. Right, hello everyone. Thanks a lot for that lovely introduction, Kaushik. That was a very lengthy, long introduction for myself. I would have probably done half that, but I'm glad that you guys know a little bit about me already. There's a few of the candidates might be knowing me from my various walks of life, and it's good to be a part of this webinar. So what I'll try and do in this is to discuss and give you certain tips and some knowledge about how to probably overcome certain techniques that I tend to use to help me get out of trouble every time I find a fractured tooth that might go on to become a surgical extraction. I have been personally providing minor oral surgery services to some of my colleagues privately, and we also had an NHS contract for a long time. Right. So to start off with, ideally what we want to do is get some idea regarding getting a very safe analysis about what we are going to start on. So clinical evaluation, along with understanding what kind of instrumentation we need, and certain techniques and tips to help us remove the roots is pretty much what we will cover today in a nutshell. Okay, we cannot ignore the current situation. Unfortunately, with COVID-19 around, we've had a stoppage to dentistry, majority of the dentistry. I know there's a few UDCs running, but most of the others are stuck. And because of that, there are going to be some changes that are going to happen. So what is being recommended now to what we'll have to provide in the future will be to eliminate aerosol production. And we'll probably have to end up removing a few teeth that we probably could have saved if we had seen them 2 or 3 months ago. And there's also the issue with more fractures of teeth happening over a period of time, that there's no care that's being provided regularly. The cases are then going to present late, and because of the late presentations and the fact that the teeth are broken down, they might end up becoming or being converted to surgical extractions. Right, let's begin with this. I know it's a scary picture, and I know that considering COVID-19, the amount of PPE anybody is wearing, including the patient, is absolutely behind our times. But the situation can be current, and this is why I wanted us to spend a little bit of time looking at this picture to give us an idea where things have gone slightly out of control. The nurse is looking away because she doesn't want to see what's happening, and the dentist is expecting to quickly get this thing done so he can get out of this situation and go back to doing routine checkups. Now, how often does this happen? And does it happen to anyone? Do we all have problems with extractions? Yes, if you're trying to extract teeth for a leopard or a jaguar like here, or if you're trying to treat. But we all do get through into situations where we think, oh, why did we start this? And is there a way out without getting my fingers bitten off, so to speak? And so let's try and work on some tips to help us get through these problems. Okay, so one of the things I wanted to discuss today would mainly be the history and the treatment planning, probably helping us assess a tooth properly before we carry out any treatment is getting a very good radiological assessment, the necessary instrumentation that we need, aseptic techniques and cross-contamination cross-contamination control, requirement of providing a flap and to be able to close it well. But these last two bits I will be covering in a separate topic, but we will discuss the first 4 ones here. Right, from a radiology point of view, these are the things I would normally look for. In this situation, we've got a lower 5 that needs to be extracted. And you can see that there's a significant dilaceration of the roots. And there are 2 curvatures, one in the middle third, and another one at the apical third, somewhere along there. And you know that with a mandible, that's quite strong. And if the patient's slightly older, you might find that the flexibility of the bone is limited, and this might turn into a surgical extraction. The radiography for a 4 is pretty adequate, although you can't see the crown. The apex can just about be seen, although I'd ideally like to see a bit more of it. But for the 6 and the 7, the apices have been lost. So ideally, you would need a better radiograph to be able to assess the apices right down to the apex and maybe a few millimeters beyond the apex to give you an idea as to how difficult or easy and what the complications could possibly be for any extraction. So slightly better radiographs here. Why I wanted to show you these is to give you the idea with the dilaceration and the acute angulations here. You can see the tip of a canine, which has got a significant curvature, a low rate that's impacted, and that's impinging right onto the ID nerve. And also wanted to discuss the sometimes overlooking the fact that a root might curve away from us. That is, then the root might be curved lingually in the lower jaw, and the root might then appear to be quite short, but actually it is longer than what it is. And it is just that the other end of the apice of the root is kind of doubled itself and folded itself back onto the root, onto the rest of the root, and therefore this might look like it's a lot easier than what it actually is, and we wouldn't find out until you start the extraction. So always beware of short roots. Medically, you would want to run through any kind of underlying medical issues. There's quite a few that I put down here. Unfortunately, the scope of this particular topic, this particular talk, is not about running through the entire medical history, because there's a lot of topics that we have to cover, especially with osteoporosis and cancers. But these are things that I think most of us are pretty aware of, and there are certain medications that you'd want to be aware of too, either for either the blood thinners or the ones that help in calcium metabolism with bone. Right, so other factors to consider would be the anxiety levels, mainly in some patients who can be quite anxious when it comes to treatment, and providing surgical procedures or long procedures on them will become very difficult. So it's important to assess someone's anxiety levels. Mouth openings and jaw disorders can also make things quite difficult. Of course, the surgical skills makes quite a big difference, and your surgical skills sometimes help you assess patients too well before, because if you've operated on patients and worked and interacted with patients for a while, you know patients who can potentially be tolerant to certain procedures and some who won't. And that will help you plan the procedure before. In this particular picture, you can quite clearly see that the patient's very nervous even for a checkup. So you'll have to really think here if a surgical procedure is possible, or if if there's a difficult route or a difficult root anatomy, then you probably have to think about providing some sedation or any other adjunct to local anesthesia. Right. Okay, so what is the advantage of learning about proper luxation and proper elevation of teeth? And although we've been taught this all the way from undergraduate levels, sometimes with time we tend to de-skill, or we tend to forget the basics that are being taught to us at that point of time. And this can make us slightly worried about going back to doing these extractions regularly. But considering the times, we might end up having to do them a lot more. So what I found personally is with the use of good luxators, mainly luxators, the surgical procedures that I used to provide has been reduced, because good luxation allows you to be less invasive, and it probably helps heal faster because you're not raising any flaps and you're not doing any sutures. So how do we start any surgical procedure? So once you've got all the medical history done and you're happy, you've consented your patients, obviously, and you run through all the list of things that you need to do before with the assessment of the radiography, and now you feel confident to start an extraction. One of the most important things that needs to be done, which many of us sometimes underdo or don't do at all, is proper elevation or luxation. Now, luxators are but elevators can be used in all teeth as long as they're used appropriately. And by using elevators and mobilizing the teeth significantly, by expanding the sockets and severing as much as the periodontal fibers as we can, That will allow some level of mobility of the whole tooth. And by then force of application, even if a root fragment fractures, you've still only got a mobile root fragment, which will become easier to elevate or luxate or remove. Right, what kind of instrumentation do we need? Obviously not this, but it's just to give us an idea as to what we need. That could be a basic surgical kit. So you need a couple of periosteal elevators. Obviously you need a scalpel and a blade, which is not on this picture. So a good set of suturing forceps. A good retractor, you can use a Minnesota retractor. What I tend to use normally is a Raikes retractor or also an Austin's retractor. Both of them work quite well. The periosteal retractors are mainly for just raising the flap, and they shouldn't be used as retractors. And you've got other instruments to help you modify or remove any bone fragments from the tooth sockets, and also some very fine apex elevators to help you remove apices of the roots. So these root working tips can be quite fine, and they work down the length of the sockets quite well. There's also an instrument called a root pick, which looks something like this curette, except that the tip of it is quite sharp and is slightly curved like this curette is, and it can be introduced into the socket to elevate the root tips out. Okay, so the main elevators that have always been in use historically have been Couplands, the Warwick James, which are the curved and the straight ones, and also the Cryers. I'll talk to you about the principles of how these elevators work very quickly, because it's something that we do need to understand. Just for you to move on before that, to give you an idea, if you elevate or to luxate around, for example, this impacted tooth, you can see the forces being applied and the pressure runs along the entire length of the mandible and also to the apices of the root and beyond the apices of the root. So by application of a lot of pressure here, you will find that if there's an ID nerve quite close by, you can apply pressure indirectly, which can still cause a loss of sensation or any damage to the ID nerve. Right, so the three principles that we've got is the lever principle, the wedge, and the wheel and axle maps. Usually the lever type of elevation is a first order lever where there's a fulcrum, there's an effort, and there's a work end. Okay, and that usually works quite well for removing roots. The wedge principle works pretty much like how a carpenter would remove a fractured nail from a piece of wood, where you very carefully place another nail right next to it to expand the site where the fractured root can be removed in a similar way. And the wheel and axle work with the rotation of the wrist and the force being applied at the working end onto the tip of the root. And I've got some pictures for us to help understand that. Here you can see that that's the elevation. You've got a fulcrum there, and that's where the effort is being put, and that's where the workload is being done. That's the wheel and axle where there's rotation, and also the wedge principle where it's going in, where there's a small wedge that's being introduced into a socket to gradually expand the tooth socket. If there's another bit of a wedge behind it, that will pop out because the expansion of the socket has happened. Right. So based on that, let's go back to the lever. The luxations so the elevations normally happen with this kind of finger rest, where you've got the handle completely stuck in the palm, and the index finger runs along the shank right up to the working tip. And then if you have a slip with this particular instrument, your fingers goes on straight onto the tooth or the tooth next to it and stops you from causing any damage to the adjacent soft tissue. So in this particular tooth, let's have a look as to what we can do regarding treating this tooth. I'll just use a pointer so it'll give me a better idea. Right, here we've got root-treated upper six, pretty curved roots, and you've got a really long palatal root. That's your floor of the sinus, and you can see the palatal root might be very close to, or in fact beyond and into the sinus. You've also got the fact that because it's a long-term root-treated tooth, there's a very good chance that the tooth might fracture because the dentine itself will not be vital, and therefore whatever flexibility the tooth had over a period of time has been lost. You've got 2 restored teeth on either side, so you don't want to put any pressure on them. And looking at these teeth, you're now thinking that there's a very good chance that this tooth, on application of a forceps, will or probably will fracture. So one of the things I would consider on a tooth where there's not much of a crown is to first luxate, as I said before, all along the buccal margins here, mainly in that mesiobuccal area, putting pressure onto this alveolar crest rather than onto the marginal ridge of the tooth. And after careful luxation and to bring about some movement, I'll very carefully divide this tooth here in that midline there through the furcation all the way up to the middle, and then go across it in a mesiodistal way. So then you've got the palatal root that is here separated from the mesiobuccal and distobuccal root. And you can then try and remove these out separately by very careful luxation. Obviously, the root that is distally tilted here will only move distally, because it will not come out that way, because this will not allow it, because this will allow it to lock in. So ideally what you'd want is, once that root has been separated, you would want to tease it from this margin here, this would be your application point, to then twist anti-clockwise so that it drops distally to you. The distal root might be a little bit easier, but with a straight long root, once both these roots have been removed, I would use a fine root forceps to grab onto the palatal part, and then the area that the sectioning has been done, and apply very gentle rotational forces, like you'd be extracting a central incisor, rather than mesiobuccal tilting, and then remove the root with minimal pressure. Right. All the complications are to... yes?
While you explained those 2 things, one was with regards to the X-rays and assessment of an X-ray, and the other one that you explained just now was about removing the upper molar, which is very close to the sinuses.
Yes.
The main issue about informing the patient and the consenting process with the complications related to these 2 things. In a situation like what you're showing right now on the screen, is obviously going to discuss in a minute, which is your oral anesthesia. How often do you have to interface about it and take consent on that front? And the other question is about eye lowers on just having a look at the X-ray and able to sort of guess if it is safe for you to remove, or how often do you want to send it off for the CT scan for a second view?
Oh, excellent. Okay. Yeah, there's 2 good questions, 2 different questions. So I'll answer the first question based on the slide that we've got now. And I'll very quickly go back to the previous ones to show you the PA we have of the lower 8 to discuss the ID canal. Okay, so from this point of view, for this particular tooth, the X-ray quite clearly shows me that we've got quite a low sinus. You can see that it's a well-aerated sinus. The floor tends to drop down quite significantly. And you can see that the palatal root is pretty much into the sinus, as far as we can tell from this X-ray, although it's only a 2-dimensional view. But when I see this, I would always mention to a patient that there's a chance you would get an oral-antral communication after the extraction, and there's also a good chance that the root might escape, one of the roots, any of the roots, might escape into the sinus during the procedure. It's just something that you can never predict, and despite your best precautions, it can happen to anyone. It's happened to me a couple of times, twice, over the last 18 years that I've been providing oral surgery. So it just goes to show that it can happen. And both my root escapes into the sinus happened pretty later in my career than in the early stages. So it just goes to show that it's not experience. It's just sometimes it's just a wrong application of pressure for a split second to allow the root to go in. So the short answer for that would be yes, I would warn every single patient where I see the roots even touching or even close to the sinus for an upper 6, that there's a chance that the roots might escape into the maxillary sinus or the antrum, yeah, or to get an oral-antral communication after the extraction is done. And the other one that you were asking me was on the radiograph. I'll very quickly go back. So for assessing of a lower wisdom tooth from extraction point of view, what you ideally do is an OPG. You can, a PA will give you a good idea, but sometimes PAs are very difficult to actually do because of the fact that patients will gag when the film is put so posteriorly. But in this situation, you've got an impacted lower eight where the distal root seems to be curving away and the mesial root seems to be curving away distally. So there seems to be some curvature there. You can see there's about three main things that I'd look at. One is the cortical plate of the ID canal. And if it is continuous and there is no deviation away from the root, then to me, that is something that is probably not very close to the nerve, but it appears so because of superimposition, i.e. the ID nerve must be either lingual or it might be, it's majority of the times is buccal to the roots of the lower eight. The next thing I'd look for is loss of continuity, where there is a sudden loss of continuity of the cortex, which we can't see, or there's no significant deviation, which cannot be seen either, or presence of any radiolucency around the site, whereby the anatomy is not very clearly seen. Having said that, nowadays, if there is a doubt, because of the fact that CT scans are so easily accessible to us, and with time and the improvement in the machines, the amount of radiation and radiation that we are providing to doing a sectional CT scan of the area is quite low compared to what it was in 2007 and 8 when CT scans are first being used. You can see, you will find that your threshold for doing CT scans has dropped because of the decrease in the radiation and the amount of information that it actually gives us. So normally I would tend to do a CT scan. If it is really close, then you have the choices of doing a coronectomy, leaving the roots in, or taking the entire tooth out as long as the patient is aware of the risks. Yeah, does that pretty much answer the question?
Yeah, thank you very much, Darshan. Yeah, that's
no worries at all.
Yeah, thanks.
Fine. I'll just go back to where we were. Sorry about that. I just want to take you back there very quickly to just be able to show you what we could possibly do as far as investigations is concerned. Right. So there we are. Right. So I put down the possibility of an OSC or an OIF, and I put them down for every single upper six eye extract, pretty much like I would put down an ID nerve damage to every single lower eight I would extract, even if the roots are miles away from the nerve, because you can get indirect pressure, as you saw from the previous slide that I showed you, where there's elevation of a tooth, and you can see the apices of beyond the apices of the root, forces were being transmitted down, and you quite easily can transmit onto the ID nerve, which can then cause its damage. Okay, right. So elevation ideally is a technique whereby you are not using the instrument in this direction, you're not elevating it here, but you're actually using your wrist to twist around. So that bit is where the elevation is from, and that's your fulcrum there, okay? So that's quite important to remember. It's not using the instrument to re-tilt it down so that the tooth can come out. Yeah? Okay, so we've got another situation where there are two fractured incisors. Trauma case, obviously. All other issues have been resolved. We've just got these two fractured roots. They're quite deep down. In my opinion, they need to be removed because they are quite low down. So there are lots of other procedures that that could be followed, but that's beyond the scope of this lecture. From my point of view, I was planning to take these two roots out. Now I look at this. What I'm looking at is the fact that there's bleeding from both the root foramen. So that gives me an idea that the canal, the pulp was vital. So these teeth will have a little bit more flexibility than the previous molar that we saw. There's also a very good crest of bone interdentally, and there seems to be a good amount of bone palatally and distally as well. What we don't know much about is the labial bone, but sometimes you don't need to expose that at all, because that labial bone is usually very thin, and that majority of the blood supply comes from this mucosa here. But in the beginning, it might be worth double checking as to prevent any slippages as well. But what you would ideally want to use is very fine luxation all along these margins here, without putting any pressure onto the teeth, using these teeth as finger rests, and I've got a picture for you to see next, and to be able to work around these roots finely into the ligament space to gradually expand the space, and to work yourself apically up to a certain extent where the roots are quite mobile, and then they can be removed. It takes a lot of patience to do that, and a lot of times you might find if there's a root that is curved, or there's a bit of a dilaceration at the tip of the root, it becomes difficult to treat or difficult to remove like that. But majority of the times, especially in central incisors, that should work quite well. So you can sometimes elevate the labial papilla, which is what I was talking about, minimally, to just be able to see what the roots are doing. And then that's exactly how that root would work. So that's a wedge principle that we discussed before, where there's a piece of triangle wood that was being knocked into a small stump and left there so that the area would expand. It's exactly what we're doing with the bone in a very controlled way. Here, this is an upper premolar that's being extracted, and you can see that pressure is being applied distally, and ideally you would come along easily and work along the labial plate, and this pressure with that finger rest on the adjacent teeth will stop us from slipping. This is pretty much the same way that you could use a luxator, in the same way where the instrument is actually running parallel to the long axis of the tooth, rather than being perpendicular or at an angle to it. So here, apart from the pain and the swelling and all the other things that you would normally expect, like bleeding, bruising, the other things that you would possibly discuss is a surgical tearing of the gum. That is something you have to be aware of. If you slip, surgical extraction is possible. If the labial plate is very thin and is being fractured already from the trauma, then a part of it might come out, and there might be further internal fractures within those roots, which might make them crumble if you're going ahead to treat. So that's something we have to remember as well. Okay, so the luxators work very similar, in a very similar principle to the wedge, like an elevator, except that the luxators are a lot sharper. The metallurgy is improved quite significantly for us to be able to provide very fine, very hard working tips, which are pretty durable. And as long as you use them in the correct way, then you won't slip with them, and then there's less chances of causing any adjacent damage. Okay? So finger rests are very important when you use luxators, and it's always important to remember that luxation can be done mainly on teeth that you can access well, and you have to be almost parallel to the tooth most of the times that you use it. They cannot be used like an elevator, where you introduce the instrument at an angle, or sometimes even at 90 degrees to the long axis of the tooth. So the idea of the luxation is to gradually expand the socket and removing the periodontal ligament fibers around it, and is ideal for single rooted teeth. I tend to use luxators for posterior teeth as well, but I try to remember to divide them first before I luxate. So you make a multi-rooted tooth as a single root segments, and then take them out separately. Okay, periotomes are very similar to luxators, except that these are finger gripped rather than in the palm, and therefore the amount of pressure that you will apply with the periotomes is very controlled. Most implantologists love using these instruments on the anterior teeth because they're able to preserve labial bone. It gives them very precise areas of application, and it takes a lot more time, but whatever is left behind in the tooth socket is minimally damaged as compared to using elevators, and therefore these instruments are they're quite technique sensitive because it takes time to get used to them. But with patience and by using them regularly on anteriors, you'll find that they're a lot more friendlier when it comes to the healing of the tooth sockets after extractions. Okay, surgical motors is something that we use most of the times. We try and, the whole idea of this lecture was to stop us from coming towards using the surgical motors by using the luxators and peritones and elevators and root picks in the right way to be able to remove those teeth. But by dividing roots, you'll find that luxators work quite well. When you don't have to raise a flap, you can still divide the roots along with the surgical motor. And I've got some pictures that I'll show them to you. Ideally, you'd want a straight handpiece. One with a LED would be better. What you've got on setting on this picture is actually for an implant motor with a contra-angled handpiece and normal saline irrigation. We use the same saline irrigation for extractions, except that the RPM can vary from 30,000 to 40,000 RPM. And that's the maximum these machines can do. And I tend to use a combination of a round bar for my initial starting and tend to do majority of my sectioning work with a fissure bar. But that's just my personal preference. I have colleagues who tend to use the round bar a lot more than they use the fissure bar. Right, here's a pretty good example of what I was discussing before. So you've got a root-filled lower 6 and you're looking at considering extracting it. It's discolored, so it is going to fracture, or it's probably going to fracture if you apply forceps on it directly. So what you can do is some initial luxation, and then finding the furcation of the root with the luxation. While luxating, you can find the furcation. Once you've seen the location of the furcation, you use a surgical handpiece like you saw before. Section the roots right through so that you get complete division. You have to be very careful not to go all the way to the lingual side, because there's a good chance you might perforate or touch the lingual cortex and you can get a lot of bleeding from there. So that's what you want to stop. You want to go about 3/4 of the way and then gradually be able to separate the roots so that they become 2 single-rooted teeth. And then it's definitely easier to extract them. Either you can elevate them or luxate them, or sometimes you can use very fine root forceps and apply very gentle rotatory motions to be able to mobilize these roots. If they're very curved, as I said before, you might find it difficult to mobilize them. Okay, so that's pretty much what we're looking at. This is obviously a photograph, or sorry, a picture or a diagram showing us after a flap has been raised. This is a very minimally invasive flap that's just showing you where the section has been done. And the second picture shows us the use of an elevator, because you can see that's the long axis of the tooth, and that is the force, that's where the instrument is being applied. So that's definitely an elevator. What you'd want is for that, if you're using a luxator, for it to go at this angle along into the buccal cortex to gradually be able to mobilize the tooth, and then use a forceps to remove it. And once this has been removed, you can either elevate the tooth slightly distally or on the buccal side to remove the distal root, or use the forceps like a fine root forceps like we discussed before. Okay, so from a wheel and axle point of view, I mean, you saw how the rotation of, so here you've got a distally fractured or a mesially fractured root, and you're using this particular instrument with a Cryas that's curved, that's locking onto the middle part of the fractured root, of the fractured mesial root, and by applying upward pressure from the sharp tip, it engages the root and then elevates it up. You must remember that a lot of force does tend to go onto the crest, and that has to be pretty much controlled by the operator. And you find that when you do these particular movements to take the root out, sometimes you damage the interradicular bone because the fracture is deeper, and sometimes you can cause a lot of damage to the adjacent tooth without realizing, because you're applying pressure onto it. Because these teeth, this molar can be a lot closer, and then as you twist backwards, this applies a lot of pressure on the adjacent teeth. So personally, I do not use them that much. Cryas and Warwick James, I normally tend to use mainly for upper posteriors, like upper third molars, But here, I tend to would have normally applied some from fine luxation on the buccal side here, and slowly work along the mesial side, and then try and move this root distally if it wants to go that way, or I would try and go with a luxator distally as well to see if it wants to go, if it's got a tilt for it to move distally that way. So I would try and preserve as much as intraradicular bone as possible, because that will help with better healing. Right, so there we've got, there's been an exaggeration of a surgical trough, like a buccal trough that's been made, a buccal gutter, to expose the two roots through the furcation and divide them, and that's coming out. But obviously in this situation, you probably have quite a bit of bone loss during the healing phase, because because of the fact that the intraradicular bone might have been damaged. Right. So considering all that we've discussed so far, I wanted to show you this particular picture. What is wrong here is what I wanted to ask the candidates, but for me, everything is wrong here. To start off with, the flap is wrong because I think they're being cut too parallelly. Normally, you'd want the flap to be slightly more flaring out, so you get a wider base, better blood supply. This papilla has been split in half. It's something I do not like. I would say you either spare the papilla completely or you involve it. But the biggest mistake, or the elephant in the room here, is the use of an aerotor to remove bone around the tooth. Ideally, the aerotors are made for cutting enamel and dentin with the diamond burr. The speed of an aerotor with the help of compressed air passing through a turbine is around 200,000, and sometimes even higher. And the amount of water that comes out is not enough to cool the bone. And so you always tend to find that there's a smell of burning bone when you're trying to do this part of bone removal. The significance of that is that it causes a lot of collateral damage to all the blood vessels here, and the healing is very compromised secondary to that. But the most important thing is the fact that this is aerosol production, and therefore we will not be able to use this for a long time. But even when we could, to me, this was never an instrument to be used for dividing roots or for providing oral surgery at all, although some people have known to use it. Another thing that it can do is, because of the force of the air that's coming out from the drill and that's being pushed into the tissue, especially where the flap is raised, that air can escape down here, run into the buccal space here, and give somebody something called a surgical emphysema. So here we've got the patient who's had an upper 5 removed. It was double rooted, so the son ended up sectioning it, and then you've got air collecting all along the buccal space, running up into the canine space and posteriorly. So that kind of swelling can be quite dramatic. Sometimes the air goes further up, and once it hits the periorbital space, it causes a significant periorbital emphysema, which is very dramatic to look at. And occasionally, with the treatment from being done from one side, it can be bilateral too. So these are things that we have to think about, and using aerotors makes patients particularly prone to getting this problem, and you would want to avoid it in all ways. So what spaces can airs escape to? I thought I'll give you a very quick idea. When you do, in that particular molar that we saw before, when you're exposing and you're raising a small flap, that air can escape straight into the submandibular space, the buccal space, and also into sublingual spaces sometimes, which can be very significant. From the uppers, you can go into infratemporal spaces, the canine space, and also the buccal space. But everything, all of these are quite self-limiting, and it does tend to improve with time. But for that 1 week or 10 days, the patient does have a significant swelling. Can be a lot more significant, as I said, if it goes around the eyes. But it is something that can be quite easily avoided by investing in a nice oral surgery motor, a surgical motor. In fact, most surgical practices that have that have an implantologist or a dentist who provides dental implants would be having that handpiece and the motor at their disposal. Another topic to quickly run through is the fracture of these very carious roots when there's rampant caries. And these roots can be very, very difficult to extract. They might look easy. In fact, some of them might have a lot of periodontal disease around them. And to us, it looks like they're going to come out quite easily. But because of the extent of root caries on the top and the fact that the other end of the apex and the middle end of the roots are quite firm, they become very difficult because there's no application points at all. What's important is to be very careful about assessing what's happening. Luxation should be done very carefully because these bits can crumble, the whole instrument can slip and run down this way, cause quite significant damage to the soft tissue. So you'd want your finger rests from your opposite hand to be here and on the palate, and very carefully apply pressure on the wedge principle or circumferentially around the root. And if you feel any movement of the root, you should sometimes feel it through the plate. And if eventually, once you've got it mobilized enough, you would want to use a very fine root forceps to be slipped underneath the mucosa on either side and apply rotational forces with increasing angles to allow the root to come out. Okay. Now, some of my colleagues are very proud about doing these things where the apex of the root fractures, but the root has been mobile. The key is that this thing works mainly when the tooth has been mobilized quite well before the fracture has happened. So what would have happened is this root was probably tilted mesially, so both of them are locking. When you're trying to do the extraction, there's no way that the roots were coming out together. But because of the fact that there's adequate luxation and mobilizing of the tooth being done, the apex would have fractured. That fracture would have been quite mobile. So then it is retrievable with the help of a very fine endophile that can be engaged into the root canal, and then the whole root and the remnant of the root can be removed with very minimal invasion. Right. So this is something that you don't necessarily have to do, but it's something that I thought I'll give you a quick idea about, because it'll give you a very good idea about removal of bone adjacent to teeth or adjacent to roots, because that's something I've not shown a picture of. So here we've got a mesioangular tooth. See that the incision has been made with a buccal relief. The lingual nerve sometimes runs on the inside here, and therefore that's why you don't want to go straight. The flap has been raised, full thickness flap, so you can see that's the bone. The periosteum is within the flap itself, and then we've made a very careful removal of bone just adjacent to the tooth, and the cortical bone has been penetrated, and the cancellous bone is seen to be bleeding there, and that's quite an important thing to see before you start taking teeth out. The impaction is being released, so it's being disimpacted. A fissure bang is used to do a coronectomy to remove the root completely, and to then section it in the middle to take it out. So the roots the crown has been removed. What's left are the roots, and here a very careful sectioning through the furcation has been done. A little bit more of buccal bone has been removed, and that allows the roots to be luxated out. So this curved distal root gives a little bit of trouble, but it has come out quite well. The socket's nice and clean, and it's been closed up. Right. Unfortunately, piedras are something that you can't use in the recent future because of the fine aerosol production that it has, but they are very useful at removing root tips because they work on the same principles like an ultrasonic scaler, except that the vibrations that run through an instrument are very, very high, and they can be used to very gradually remove and sever the periodontal ligament fibers of a fractured root tip, and the pretty bloodless field that you get, and the roots can be removed with very minimal invasion.
Darshan, if I can just interrupt you here, sorry.
Yeah.
There's one question from my good friend Ajay,
Yeah.
who's asking if there is a small little root tip that is left in the socket, how safe is it to leave that root rather than meddle with it? Because the complications of meddling with that root could be sometimes devastating.
Yes, I mean, depending, so all this depends on the anatomy of the area. So if you're working on an upper molar and the mesiobuccal root apex is fractured, and you can feel it is being really close to the sinus, and you're worried that you might push it into the sinus floor, or you're extracting a lower 8 and an apex is fractured, and that you'd assess from a CT scan or an X-ray before that it's really close to the ID nerve. And see, most of the procedures that we are discussing now, like very careful luxation, application of pressure in the right areas, is something that is not that invasive. It's pretty non-invasive. So you can try and take the root out, but if you feel that there's no periapical infection around it, the root is fractured, it's deep down, we normally take out teeth only when there is a significant infection. So therefore, you would expect most of these roots to be infected, apart from low rates where you take them out if they've got pericoronitis, or for orthodontic extractions. And in those situations, small fragments of roots can be monitored. And I say that on the basis that if you haven't treated it, but on the other hand, there is a risk that you could potentially get an infection from these roots, although the risk is quite low of that. Yeah.
Yeah, that's wonderful. I think that should answer Ajay's question. But also, I think quite a few of them are going to be interested on what kind of flap we need to raise in situations like this. You did point about one of the flaps which you didn't think was very, very safe and good. I think we have a separate session for flap design and suturing technique because it needs much more time to explain. So Darshan has been kind enough to say, I'm going to run a complete session on flaps and sutures because it's a very, very, very important topic. Is that right, Darshan?
Yeah, that's a good point, especially in conjunction with this talk, when the elevation and luxation of using peritones doesn't work very well. The next step is to consider raising a very careful flap and then to remove a tiny bit of bone, which we've kind of all covered in this talk as well. But to do that, sometimes you have to raise a very careful flap, and providing and raising of flaps and closing them is very much part of removing roots very carefully. So hence why I thought I'd do a second lecture, and we can add in some more points and some more tips to that lecture too, so as to kind of complete. But to do it all in one lecture, I found would be losing a lot of important bits.
Yeah, that'd be good. That'd be good. So yeah, I'll let you carry on, Darshan.
No, it's fine. We're almost there. I'll just run through this very quickly. So this is what we have come to now: cross-infection control, where you need to be wearing a lot of masks and a lot of gear rather than a simple extraction. You'll need high filtration masks as well in the future. This is what my opinion is, although we haven't been told exactly what we will need, but this, considering what we are facing and the lockdown that we are in, I think for dentistry to be practiced and to reduce cross-contamination, there'll be a lot of regulations which might probably end up looking like that, providing treatment. The only difference would be the masks, because here none of my colleagues seem to be wearing any masks here, but that's what we'll have to go on as well. Okay, most of the talk I did was not from a textbook. It's all my personal experience because I've been doing this for so long. But I also read a lot. I have a passion for reading, and I've read quite a few of these books which I've put down because they are very useful at giving you some tips as to how to progress. And whatever I've talked is also there in these books. So it's an option if you want further reading. We've got some bits and pieces there. So in conclusion, I'd like to say that in the situation that we're in now and what we are going to be doing in the future, there'll be quite a few extractions that might have to be done. And you might find that as a dental practitioner, general dental practitioner, the number of oral surgery procedures that you're ending up doing will increase slightly because of a limitation of the provision of treatments that we'll be allowed to do. But there'll also be a lot of late presentations, which could possibly mean some more challenging extractions, and referrals to PCT MOS centers might take a lot longer. So we might want to hone up our skills, read up on them, and work on them with time. And with time, we'll all improve. Surgical skills only improve with time. And no matter how many books we read, it is a practical, it's practical knowledge, and it's a skill that improves with time. Okay. So from that point of view, one last thing I wanted to tell you was about the careful assessment prior to starting, which either makes your case very difficult or very easy to treat. Thank you for your patience of listening to me, and I'll pass you straight back on to Kaushik from here on.
Thank you very much, Darshan.
If you have any questions, just come back to you.
Stop sharing your screen.
Yeah,
so.
I've done that.
It was an amazing lecture. I truly enjoyed it, especially coming to the fact that we have, within a span of 2 months, moved from a concept of no extraction to a concept of all extraction. So you and I had to sort of warm up my hands to such kind of a situation. Going further, just before we take on questions, I just go through the set of webinars that are lined up for you guys, so you have an exact idea of what's going on as we go forward. The next one's going to be from Dr. Akshay Jamadagni, and he'll be talking about orthodontics simplified, because all the time we'll be hearing so much about different aspects of orthodontics, and we have no clue of how to integrate it into our general dental practice. This is a very, very basic knowledge-filled process of how you combine orthodontics with your day-to-day dentistry to make it less invasive and to make it more effective and efficient. It's not only very good for the patients, but it's also good as a business. So Akshay does it all the time, and this is going to be a wonderful lecture on how he is going to explain the concepts, how you can integrate that into day-to-day practice. That's going to come on the 14th of May, 2020 at 3 p.m. Following that, on the 15th, we have a wonderful accountant. He's a specialist dental accountant, and he talks about money matters. And I think this is very important right now, post-COVID, on how are we going to get our money and how we're going to deal with it, and where we can save and where we can spend. So Wakanawaz is going to take that on the 15th of May. You can have any number of questions that you want, and that's going to be something we'll answer. On the 21st of May, we have Dr. Tarun Kumar. He's an international, very, very well-known speaker. He is speaking about guided bone regeneration concepts and techniques. And between Dr. Tarun Kumar and Dr. Darshan, you should have a very, very good concept of bone regeneration, flap design, and suturing techniques. Once you have a good idea of these things, I think it helps you in most of the day-to-day processes that we are more or less starting to look at post-COVID-19. So he is going to be dealing with that. He is also a diplomat in the International Congress of Implantologists. He's a specialist periodontist, and I'm looking forward to that lecture. That's on the 21st of May, 2020. And the last one for this month would be, I think, my favorite one, and the one that I'm really, really looking forward to, that is lasers in daily dental practice. Of course, in Dental Roots, we did run a few webinars for dental lasers, but they were for people who were already using lasers. And the feedback we got was that people wanted to know what actually lasers are, because this is not something that was taught in the undergrad. These are concepts that has evolved over the last few years, and it's something with a bang. And especially after COVID with aerosol and these kinds of things, it's taken a big sort of leap in the way you integrate dental lasers into practice. Dr. is a specialist oral surgeon, and she's a PhD in dental lasers. She's one of the main persons in dental lasers in the UK, and she's agreed to give us a talk about the exact who and what of dental lasers. It's going to be what is dental laser, how is it important in dentistry, and what the future holds for lasers in dentistry. That's on the 28th of May. So that's the set put together for you. Darshan, of course, is coming back again on the 18th, talking about his journey when he had to suffer COVID-19 himself. He, as I explained to you in the beginning, he is one of those guys who's so passionate about his job. He went on to be on the front line, and he contracted COVID-19. And it is nice for us to sort of get a view of how it all feels, because we all can be there at some stage or the other. And as we explained before, contemporary flap design and sutures is again handled by Darshan on the 25th of May 2020. I'll quickly run through how you take your CPD. You can just go back to the website where you're registered, which is www.dentalroots.org. And if you look at the picture on the right side here, all you need to do is to press on the complete course quiz button below this particular webinar. It will get you the quiz questions, finish it off, have your feedback answered, and you should be able to download your CPDs. That's wonderful. So I'll get Darshan to take on any questions. If anyone has any questions here, let me go through some of those. So, Darshan, how is it important, or what is the protocol you think we guys are going to have to take in terms of future referrals, in terms of we trying to deal with these extractions, any complications that we can encounter, and what do you think would be the way forward?
So that pretty much depends. See, what will happen overall, I think, I mean, none of us are experts on COVID-19 as yet, nor do we know exactly what the CDO is going to put out for us in the future. But what we do know and what we can expect is that there will be a reduction in aerosol production, which will therefore move on to us providing a lot more oral surgery. And this is pretty much a very personal skill that some dentists are very interested in and they've kept up, and others have slowly lost over a period of time. Obviously, we tend to restore a lot more teeth than we extract, and therefore it can be a lot of de-skilling that happens. So it pretty much depends on a personal skill as to how much of they want to attempt or how much they don't. But because of what we are facing, I think it's important for everyone to understand that providing extractions is going to become more common, and therefore everyone will have to start providing this at some point. And based on that, it's important to kind of relearn a lot of things that you might have forgotten, which is what was the idea of this lecture.
Okay. And also coming to that, the other thing people would like to know is in acute emergency situation like an abscess or some kind of ongoing pain symptom, how do you think we should be able to handle that?
Right now or after?
Yeah. Yeah, I think we will. As soon as we start to go back, there's a lot of people who have had a course of antibiotics taken already, who still have some pain counter to that. Are we going to give you another course of antibiotics? Are we going to do an extraction? And in a situation where there is some amount of pain, I'm in a bit of a dilemma whether to give antibiotics, whether to extract the teeth. What are your sort of thoughts about it?
I think from when the time we'll be allowed to go back to work, and from the time that if we have clear guidelines regarding cross-infection control, and if you can follow them, then providing extractions has always been, or providing pulp extirpation or extractions has always been our mode of treatment for all emergencies before. So I can't see as to why not we could go back to doing that, and we'd probably end up doing a lot more extractions than pulp extirpations, because patients would have lost a little bit of patience having waited for so long to having treatment done. And they might say, look, I've been suffering this pain for so long, no treatment has been provided, I'd rather have this removed, and you move on. So that is something that might happen. But overall, I think that these are the two steps that we've used to be providing before in emergencies, and that's what we need to provide still. I just read one of a question from Diane. She said she's broken her first fractured tuberosity just over a year ago, and after 30 years experience, why operate? I was being so careful. No, I totally understand that fractured tuberosity is something that can happen to most of us, especially when we use a Cryers or a Warwick James. where you're applying a lot of pressure to distalize the upper molar, if you understand what I'm trying to say, because normally there's not too much bone apart from the tuberosity giving support to an upper eight. So when you apply pressure mesially and then try and move the tooth distally and buccally, sometimes the tuberosity is very well attached to the tooth, and that can make the root fracture. Why it happens and when it does is very difficult to explain. Sometimes the tuberosities are quite large and they're attached to the tooth very well. But when you use luxators, rather than using a Warwick James from the beginning or any of the elevators from the beginning, you tend to be able to mobilize the tuberosity away from the tooth, or you tend to be able to mobilize the tooth quite a lot so as to then have the tuberosity intact. I normally tend to put a finger on the tuberosity to see if it is moving or not when an extraction is being done. And if I feel the tuberosity is moving, and if it is a small tuberosity that's moving with the tooth, I would have explained this to the patient before anyway, that the tuberosity could fracture, and so I'd carefully take it out. And if there's an oral-antral communication, I would close it and suture it over. But it can happen, unfortunately. Sometimes it's just the anatomy that we can't understand, because from a periapical, there's a lot of fine intricate structures, fine intricate bits that we tend to miss out on, and it's impossible for us right now to do a CT scan for every upper eight we extract. So it can happen sometimes.
Thank you. There's a question from Dariush. Hi, Dariush. And he asks here, what procedures do you recommend to protect the socket?
Okay, socket preservation is something that is slightly beyond. There wasn't much of the top of this topic, but there's a lot you can do to preserve the socket even during the extraction procedures. What I would suggest is to apply very minimal pressure onto all the bone or onto the alveolar crest, especially at the occlusal end of the alveolus, where a lot of pressure and a lot of force is being applied, because the sole purpose was to remove the tooth. And when you're doing that, you can cause a lot of collateral damage. And hence why it's important to understand, to be able to concentrate more on the tooth itself. Try and always think about the socket when you're taking the tooth out. And that, by applying very minimal pressure, whatever pressure is being applied needs to run along the long axis of the tooth and into the periodontal ligament fibers, and to gradually expand the socket. So in that way, you're preserving your socket. So by preserving interradicular bone, by removing very minimal of the alveolar crest, or reducing your risks of providing these buccal gutters that I was talking about before for that wisdom tooth, by reducing that type of procedures, you're preserving your socket. But of course, you can use collagen sponges afterwards to preserve your socket. You can use bone graft. There's a lot of papers to say that these tend to work and help you maintain the sockets on the long run. But that is something probably Tarun will cover in his talk as well.
Yeah, that's true. Yeah, he's quite into those things. And also, there's another question, Darshan, from Deep. Hello, Deep. And Deep asks you, had a patient with the OSA, what are the steps to take when it happens?
Yes, good question, Deep. Unfortunately, OSCs are something that can come onto us, especially when you're extracting upper 3, all the way from the 3 to the 6s are probably the most common, but sometimes it can even happen with a 7 or an 8. So any of those teeth, when you do extract them, depending on the size of the sinus and how close it is with the roots, you can get an oral-antral communication. If the communication is very minimal, in fact, there's some people say that most of the upper teeth that we extract cause some level of oral-antral communication, but because the surgeon and the patient are unaware of it, as long as you give them your universal precautions of not blowing the nose, not putting any excess pressure onto the floor, not to poke around the site and to explore it, but to allow it to heal, generally a blood clot will help close the sinus over, and a closure of the mucosa will allow the oral-antral communication, the small oral-antral communications, to close up by themselves. Only if you see a big oral-antral communication that's causing a lot of air escape, do you need to close it. And there's certain procedures that you can do where it is minimal. Then you can do a buccal advancement flap to close it over, or you can even use a small flap from the palate to rotate across it. But in the initial stages, I would just advise, especially in small communications that you would see from routine extractions, I would just advise very conservative management, and then calling the patient back to review to see if the closure, the communication is closing over or not.
Oh,
Is that clear?
Thank you very much.
No
Yeah,
problem.
that's very clear, Darshan. That's very clear. So I don't know if anyone else has any questions. Also, what you guys can do, if you have any questions or you need any clarification or you need any further information, and also if you need any particular courses that you guys like or any particular webinars you guys like, please email us at hello@dentalroots.org. So that's hello@dentalroots.org, and we'll try and answer all your questions and try and see what best we can do in those regards. Thanks you all for attending the course today, and we all would be very, very excited to look forward to see you back again on the 14th. That's for Dr. Akshay on the Orthodontics Simplified. I think we all can leave and enjoy a wonderful sunny evening today. Thank you, Jay, for your help up there, and Dr. Senthil for your help up there as well. It was an amazing afternoon, and I'm really lusty with so much information. Should go back and digest those. Thank you very much, guys.
Sounds good.
Hey guys.
Thank you.
Bye-bye.
Thanks a lot for having me. Thanks.
Thank you.
Bye.
Bye.